Welcome back, everyone, to another edition of The Explainer. Today, we're diving straight into something huge, a massive structural overhaul that's coming to maternity care coding. If you're working in a practice for handling revenue cycle management for obstetric services, you really need to listen up. By September 1st, 2026, the entire landscape of how we bill for maternity care is going to completely change. And we're not just talking about tweaking a code here or there. I know this is a top-to-bottom teardown and rebuild of the CPT guidelines for maternity services.
Okay, let's dive right into this because Dr. John Horton, who actually sits on the CPT Maternity Care Services Workgroup, hits the nail right on the head. He says, the change is happening now. Within the next few weeks, we'll start to see patients who will deliver past the code change date. When you really think about the biological reality of that timeline, it's pretty wild. Pregnancy is 9 months long. That means a patient coming into your clinic for their very first prenatal visit early in the year is going to be delivering their baby right exactly as this massive administrative deadline drops. So the clock isn't just ticking toward 2026, it's literally ticking right now.
So here's our blueprint for today's explainer. First, the maternity code countdown. Second, goodbye global, hello segmentation. Third, we'll look at the new labor code mechanics. Fourth, aligning practitioners and documentation. Fifth, engaging payers and EHR vendors. And finally, number 6, surviving the short-term workload.
All right, kicking things off with Section 1, the Maternity Code Countdown.
We really have to connect the biological reality of a 9-month pregnancy directly to this strict administrative deadline. Because, let's be honest, babies absolutely do not care about our CPT coding calendars. If a pregnancy has its first 10-week visit between January 1st and August 31st of 2026, you're going to use the current global obstetrician codes. But, and this is a big but, here's your hard cutoff. Starting September 1st, 2026, the very first prenatal visit after confirming a pregnancy absolutely must be billed with EM codes and the appropriate ICD-10-CM codes. So what does this actually mean for you? It means you're going to have this long overlap period where your clinic is juggling patients under 2 totally different coding structures at the exact same time.
Moving right along to Section 2, goodbye global, hello segmentation.
Now, what's really interesting about this slide is comparing where we've been to where we're going. When Dr. Horton was asked when practices should prepare for this full structural change, his answer was just, start now. And here's exactly why. For years, we've relied on a global code structure, right? A single, bundled package that covers months and months of care. Well, tomorrow's reality is a completely segmented structure. We're shifting away from that comfy blanket code to a totally deconstructed model. You'll now be reporting antepartum and postpartum encounters using specific evaluation and management codes based on the setting, and that's going to be completely separated from the actual labor management codes.
And honestly, here is the hard fact that every single coder and biller needs to internalize today. CPT code 59400 for routine obstetric care, it is being completely deleted. Just gone. There's going to be a brand new parenthetical guideline officially instructing coders that all antepartum and postpartum encounters now rely strictly on those setting-appropriate E/M codes. The staple code of OB billing is being literally wiped off the books. That means the entire daily workflow of your revenue cycle has to be completely rewired from the ground up.
Okay, that brings us to Section 3, the new labor code mechanics.
So how in the world do we actually code for the incredibly demanding process of labor management now? Well, daily services are essentially being sliced up into 4 specific codes, and it all comes down to 2 decision points. First off is the encounter initial or subsequent, and second is the complexity straightforward or complex. For example, an initial straightforward encounter is 59080, but if it's an initial complex one, that bumps up to 59081. Same goes for subsequent encounters. Straightforward is 59082, and complex is 59083. Now, the guidelines explicitly spell out what makes something straightforward versus complex, so your documentation has to be incredibly precise to back up the exact path you end up taking.
Let's look at Section 4, aligning practitioners and documentation.
Because, codes don't just write themselves, right? They rely 100% on your practitioners. Dr. Horton strongly advises putting a clear internal transition strategy in place. Step 1, you need to sit down and discuss this antepartum EM switch with your providers immediately. Since prenatal care stretches out over so many months, you literally cannot wait. Step 2, run an internal review of your current global period documentation just to make sure it actually meets those strict EM standards. You really need to figure out right now if your providers are going to need extra EM training. Because if they're still dictating those brief, global-style notes come September 2026, those individual claims are going to face some massive, massive denials.
Which leads perfectly into Section 5, engaging payers and EHR vendors.
Listen, you absolutely cannot afford to sit around and wait passively for the outside world to catch up to you. First things first, reach out to your payers proactively. ACOG actually put together a dedicated toolkit that has exact talking points designed specifically for these payer conversations. It's a lifesaver. But even more importantly, get on the phone with your electronic health record vendors right away. You have to verify that their systems will be fully updated to handle these new segmented codes well before that September 1st deadline. Think about it. If your EHR isn't ready and those new labor codes aren't loaded into the system, your practice's cash flow is going to completely grind to a halt.
All right, our final section, number 6, surviving the short-term workload.
I really want to read this quote from Dr. Horton, mostly because I think it perfectly validates what so many of you are probably feeling in your gut right now. He says, "I would anticipate a need for increased code review, education, and claim validation work." And yeah, he is spot on. Coders, billers, revenue cycle managers, you all should definitely be prepared to put in some serious extra hours during and right after this transition. Your claim staff are going to need dedicated training. You'll need to do a full inventory of all the coding and billing tools your practice currently relies on and probably completely revise them. There is, without a doubt, a very real transition bump in workload heading your way.
But hey, the good news is you are definitely not alone in this. There is a massive safety net of resources already being deployed to help you out. The AMA has a whole bunch of training materials, including dedicated webinars right on their website. ACOG has already made its guidelines available to the public, with even more info actively on the way. Plus, if you're an ACOG member, keep an eye out for local, in-person training opportunities and town halls popping up very soon. Please, take advantage of this massive training push. Use these webinars, read the guidelines, go to the town halls, and train your staff so you can validate your new workflows way before that deadline ever hits.
Which brings us to the final, absolutely critical question that you have to ask yourself and your practice leadership today. Like Dr. Horton reminded us, the patients walking into your clinic very soon are going to be delivering past the structural overhaul date. Your patients will be ready to deliver, but will your practice be ready to bill for it? The time to start deconstructing those old global billing habits and mastering these new segmented EMM and labor codes is right now. Go grab those guidelines, get in touch with your payers and EHR vendors, and start bulletproofing your documentation. Thanks so much for hanging out with me for this explainer, and best of luck with the big transition.